As some of you know, we did a pilot last year on taking Medicare claims data and putting it into personal health records. That was a successful pilot. We're pushing ahead with the next set of activities. And what underlies that next set of activities is the idea that the data that CMS as an agency has collected about our Medicare or Medicaid beneficiaries should be made available back to those beneficiaries. So we're looking at ways that CMS effectively as an insurance carrier, but also as a gatherer of information that might be more clinical in nature, can participate in the network of SNOs that David was describing in his keynote. That information does belong to the patients. We'd like to find a way to make that information available to the patient, both for applications like disability determination, but also for more general health support. We're also doing one very interesting program that isn't a PHR program, but is very relevant. Because while we don't do a lot of nationally regulated assessments for disability, we do a lot for post-acute care, and we do a lot for payment. Right now, after a patient is discharged from a hospital, they might end up in a skilled nursing facility, they might end up in an inpatient rehabilitation facility. We have a variety of different systems that many of you are probably familiar with on either the issuing or the receiving side. The MDS, the OASIS system, the IRF-PI, which is used in inpatient rehab facilities. We had a mandate at CMS under the Deficit Reduction Act to create a new mechanism for post-acute care assessment. And this is a very clinical process. It involves functional assessments. It involves social and living status issues that aren't necessarily medical records in the strictest sense, but are still very relevant to a patient's care. It also often involves laboratory results. It often involves medication summaries at point of discharge, all of which are very important data elements that go into this broader personal health record environment. CMS contracted recently with RTI to develop what's called CARE, the Continuity Assessment Record and Evaluation, which has been prototyped, and they're actually doing, I believe this week, some initial evaluation studies on it. It's something that I would encourage everyone to look into a little bit more. I can talk about it in a little bit more detail, either individually or in questions if people want. You can actually go to the CMS website and you can download the post-acute care reform plan. And what I sort of encourage people to do is to cross-reference a little bit. The other hat that I wear outside of CMS, and it's the hat that I'm going back to full-time, is with Harvard and MIT. And just when David was talking about the Connecting for Health Common Framework, I wanted to talk a little bit about one program that we're doing at MIT, which is actually building what we call a personally controlled health record server, but is that consumer SNO or consumer access service that acts as that mediator between the providers of data and the patient, both giving them the mechanism to make the control decisions about how their personal health record information is shared, and potentially providing the aggregation source for that as well. We're actually going live in September with a relatively small pilot. It's only going to be about 20 or 30,000 available patients, but it's going to be the entire student, faculty, and staff population of the Massachusetts Institute of Technology. So it's going to be interesting to give all the undergraduates PHRs that are fed from actual clinical systems and that have a research agenda attached to it that is going to allow us to look at some population health issues within that structure. And what we're hoping that we'll do is that we'll learn a lot in that context about not just the technical mechanics of bringing all this information together, but the psychosocial factors of how, in this case, a relatively healthy, relatively well-educated subset of people interact with personal health records. And, again, as I keep referring back, I keep pointing at David, but some of the issues that he outlined about uncertainty about having all this information available in an electronic form.